Right, okay, so what I'll talk about, a little bit about what PHNs are and what they're supposed to do, how you can engage with or make contact with the PHNs, talk a bit about commissioning. Commissioning's essentially how we distribute the money that we get from the federal government, and then talk about how the PHNs were involved in chronic disease management, which is obviously the area of particular interest for all of you people. So there's 31 PHNs around the country, and that was they sort of replaced the Medicare locals, which used to exist. Because there's only 31, they have much larger geographic areas, and I'll talk a bit about the size of our area in a moment. The design, I mean, like it says on the slide, it's to increase the efficiency and effectiveness of medical services for patients, but more particularly those who are at risk of poor health outcomes. I mean, increasingly we're getting a bit involved in sort of the rising risk type of patient, but it's mainly those who find it hard to get the care and to manage their illnesses. And to improve the coordination of care, and I'll talk a fair bit about that when I talk about the chronic disease stuff. So it's, it's all about not just being sick and seeing this doctor for this and this physio for this and this specialist for this and this organisation for that, but having the whole thing a little bit more coordinated. And we have, like everybody else these days, we have performance indicators. The government give us money, we've got to do a variety of things, but they're national performance indicators. So one PHN could be doing exceptionally well, but if all the other ones are doing poorly, then that reflects on everyone. And it's about reducing potentially preventable hospitalisation. I mean, it's pretty much recognised that people who turn up in, you don't need to photograph them, you can have a copy of them if you like.
Thank you.
It's pretty well recognised that people who turn up at hospital when they don't need to be there, clutter up emergency departments, clutter up wards, and take the time and the service and the real estate, if you like, in hospitals away from the patients who really need it. If they're managed properly and appropriately outside of the hospital, that's actually better for them and cost less money for the government, which is probably at the base of a lot of these things. They want to increase childhood immunisation rates. Childhood immunisation rates ideally would be around 95% of the population, and according to the people who know about numbers, that's the herd amount, and if 95% is done across the country, then that's good. It's probably at 92, 93, so it's pretty high, but that 2 or 3% is, so they tell us, quite significant. It seems still like a lot, but it's an issue. Increasing cancer screening rates, specifically for cervical, breast and bowel cancer, more than anything else. They're the sort of the 3 targeted ones by the government. And increasing mental health treatment rates. So I'll show you a chart later on of how our PHN spends its money, which is relatively similar to the others. And you can see that mental health is a huge component of what the PHNs do. So what do they actually do? In short, distribute government funding in programs designed to meet the strategic goals. So we've all got different organisational goals and different strategic plans, but broadly we need to meet those same requirements that I talked about in the previous slide. And we work with providers to support them to improve systems, processes, to enable better outcomes. So this is all about doing things better and having an optimal outcome for patients, which, as you would probably understand, is difficult to measure because it takes a long time to see whether this intervention has actually had some real benefit. Okay, so because I'm not sure exactly where all of you people come from and because the video might be going further around the state, what I've got is a map here that shows so there's 6 PHNs in Victoria, and this just gives an idea of where your PHN might be. So you can see there's the 3 large regional ones and then 3 in Melbourne, southeast, east and northwest. So that gives you an idea of the PHN that you might be best working with or approaching to do things. I have also provided their names and the email addresses. What I would strongly encourage people to do is, having worked out which your PHN might be, have a look on their website, see what it is they're doing. So much of what I'm talking about is going to be the generality of what all of us do, but the specifics of what our one does. But by going onto their websites, you can see what the individual PHNs are doing and how what they're doing might tally with the particular interest of your organisations. Okay, so South East Melbourne PHN. So we've got about 1.5 million people, 3,000 square kilometres, and we basically cover from St Kilda up the top, all the way down the Mornington Peninsula and out to Bunyip. So it matches precisely with local government areas. So we have 10 local government areas. The edge ones are Casey and Cardinia, the two out the far end. And we come up as far north as Stonington, Glen Ira and Port Phillip. And then obviously our adjoining PHN is Eastern, where we have a solid boundary with them, a little bit with Gippsland and a little bit with northwest Melbourne. So those of you who are involved in the city area, depending on exactly where you are, you could find there's a need to deal with more than one PHN, but it's essentially local government area boundaries that fit neatly within, which is different to the hospital boundaries. So Monash Health, for example, straddle 2 PHNs. Alfred Health sort of straddle 2, or they're predominantly ours, but other health services are across a couple of them. And places like Murray, up in the north of the state, have got about 40 different health services that they have to deal with because that's such a huge geographic area. Okay, so what do we do? And like I say, most of the other PHNs do very similar. So we have mental health, both accessible psychiatric interventions, which some of you might have heard of the ATAPS program, which is being replaced by the API program. It's the same in concept. This is for patients with low-level mental illness, and it's about access to treatment and psychologists and the like. I can never remember what one of the other ones is, but it's, some of you might have heard of the MANIP nurses. That's a more severe psychiatric conditions managed generally out of general practices. We are the fund holders for the various headspace centres in our area, suicide prevention activities. We also fund Partners in Recovery program, which is for people with severe mental health issues, and Indigenous mental health as well. We provide funding specifically for that because, as you'd be aware, there's various amounts of specific funding for Indigenous, separate often to the funding for the broader population. We're involved with alcohol and drugs, so SACADA, which is the South East Consortium of Alcohol and Drug Agencies. So again, that's counselling and treatment for people with severe alcohol and other drug disorders. We have federally funded drug and alcohol programs, again Indigenous alcohol and drug programs. Chronic disease, we are a healthcare homes site. I'll explain what healthcare homes is about in a little bit. We also do various capacity building activities for general practice to help them better manage chronic disease patients. State government, so most of our funding is federal government funding, but because of the size of the PHNs, the state governments are getting quite interested. So we participate in the state program for GPs in schools, which is a currently rolling out program of placing a GP in secondary schools, basically, where there's proven to be a low on the social indicators, such that the students are less likely to actually be seeing a GP with any sort of regularity. We're not getting a picture of exactly what they're seeing them for, but the ones that have started are proving to be quite well used. Immunisation, of course, both childhood and adult. Now, we don't do the immunisation. In fact, we don't really do terribly much at all. We provide funding to support other organisations to do the things. Cancer screening, digital health, excuse me, working on the recognition that having using digital and technology appropriately does have some benefits. It's not about making all health digital. It's about where using technology can enhance healthcare and health management. And integrated team care, which is the Indigenous Health Program, which is essentially a chronic disease program for the Indigenous community. Okay, so this just gives you an idea. I was talking before about the money that we've got. So in 17-18, we're going to have about $46 million to distribute. But as you can see from the chart, in excess of half of it is mental health. So mental health for the federal government is huge. They want and are trying to get significant reforms in mental health. And that reflects in the amount of money. The other thing to consider is the headspaces and the youth early psychosis programs are quite significant amounts of funding, and we're essentially the administrator of them. Yeah, the arrangements are done, we receive the money, we contract the providers and give it to them. So that actually takes a large amount of that orange, it's almost passed through. There's $20 or $30 million that we basically don't really, we see it and then it's gone straight out the door again. But it also shows, and the chronic disease area tends to come out of the flex, which is the 12% one on the sort of between midday and 1 o'clock. So we've got about $5 million that we have to spend on various chronic disease programs. But I thought I'd include that one just to give you an idea of where the money is and, if you like, how much money there isn't for chronic disease. Now, you could assume that the other 6 PHNs, their charts would look pretty much the same, would be my guess. Okay, so primary health. So what this is all about is that primary health is very much changing from what it used to be. And the idea is it's about the patient. This is just one of those slides that people like to use. It's got all the words in it, but it's really about not imposing stuff upon people, but having consultation with patients, with providers, with peak organisations, with support organisations. You know, the word co-design gets bandied about, and the social model of health and all that sort of stuff. It's really about considering the patient and what the patient may or may not need, rather than telling the patient what they need, which, as you all know, is usually not right. The government doesn't usually know how that works. It's better off to get the people who do know as part of the conversations. So as I say, it's about having the patient at the middle of it. So you're looking at coordinated care, performance improvement, focus on the wellness. It's, as I said early on, it's essentially about keeping people out of a hospital unnecessarily by having good systems and processes in place earlier in their process. Okay, and so better local health care. So it's improving access, commissioning new services, and supporting clinicians to innovate. One of the big problems, if you like, with particularly general practice is general practice is funded for the GP to see the patient and do something with the patient. If the GP doesn't do something with the patient, the practice doesn't get any money, so they often don't do it. Not because they don't want to, but because there's nothing, they can't afford to. I say there's nothing in it for them, which makes it sound like they're all messing around. I don't mean it in that way. But they've got to be able to see that if they're going to be a bit innovative, then there's something in it for them, and they can see the benefit for the patients as well. So the way we're trying to do things, in theory, encourages some of that innovation. And we've had a number of commissioning activities where we've sought innovative ideas and innovative responses to problems. So commissioning. So I've talked about commissioning, so now I'll explain a bit about what it means. So it's like everything else, it's one of those continuous processes where we're responsible for strategic planning. So that's looking at the needs of the community, the available health services, working out the priorities, and then buying services. So when we talk about the needs of the community, one of the things that we're finding with what we do at the moment is we've got lots and lots of maps from our data guys who have worked out where the areas of need are. So what the strategic planning part of it is about is trying to improve services and put services into places where they're required. So I'll use a mental health example. I know this isn't really about mental health, but it conveys it a little bit. If you look at our charting, the greatest area of need for mental health services is Casey, Cardinia and Dandenong. The greatest concentration of providers who can meet that need is in Stonington, which, as you would know, is nowhere near Casey and Cardinia. And so what we're doing is seeking to focus where we can fund and support into those areas that need it, rather than the areas that, it's not that they don't need it, but they're very well serviced, the inner city. And of all of the maps that we have in terms of, you know, where's the greatest need, we have 5 of our local government areas come up in the top 5 pretty much every single time, and that's Casey, it's Cardinia, it's Dandenong and it's Frankston. We'll have those 4 are always in the top 5, and number 5 is either Mornington Peninsula or Port Phillip, almost exclusively. The other 5 are always in the bottom half, but they're the more inner suburbs which have got a greater concentration of service. So what that leads to is people complaining sometimes when we'll fund a whole bunch of services in Pakenham and we didn't fund the services in Brighton. That's sort of because Brighton didn't necessarily need the services. But that's part of that strategic approach. And like I say, when you look at the various maps, it becomes a bit more obvious as to why that happens. So once we've worked out excuse me, where the services are going to be and what it is that we need to be able to do, so that's where we've had conversations and discussions with providers, peak bodies, consumer groups. We then work out broadly what it is we need to do, and then we seek to procure the services. So we, in essence, have a tender and say, who wants to provide this service in this area? And then a variety of organisations respond. And so the process is fairly robust, but we will then provide them with money in order to provide the services. But then we monitor and review the services as well. So once, you know, it's all very well to give someone $100,000 to do something, but you've got to make sure that it's actually working and that it's sustainable. Because otherwise you might as well have thrown the $100,000 away because nothing really happens from it. And it could be that you need to tweak what you've done, that it's not worked as well as it could. And so that's quite a big process, the monitoring and review part of it. So how exactly does our role work? This chart makes it, I think, fairly clear, and in terms of what I've just been talking about. So the money comes in from the federal government in a variety of forms. we have a look, can we integrate it? Is there value for money? Is it person-centred? Is it data-driven? So when I talk about data-driven, that's what I was talking about before. The service is needed here and all the data supports that, then that's where the service will be, not where the noisy people want their service who might not need it. The focus is getting better health outcomes, and then the money goes to delivering local services. So the basic principles of commissioning, it's consumer-driven choice. So that's through the engagement and co-design, incorporating a social model of health. So it's looking at not all problems are in the health space. One of the things we're looking at a little bit at the moment is what's known as social prescription or green prescription, where it's well recognised internationally that if people, it's a bit like support groups, but it's instead of going to see the GP might prescribe and say, what you need to do, Mrs. Smith, is go and meet at this group and walk for 1 kilometre once a week. And so what that happens is the person gets a bit of exercise, but more importantly, they meet as part of a walking group of maybe 4 people, maybe half a dozen people, who are probably all got similar issues. So they talk about what their problems are, how they're managing things, how they're not managing things. And there's a whole heap of international evidence that shows that that sort of thing has a significant benefit on people with chronic disease. It's about being agile and responsive. Sorry about this, I've got notes which I'm not a regular user of. I can't read them all at once at the moment. I might skip the notes. And so what we're talking about with agile and responsive is not saying, here's money and this program's going to last 10 years and you must do this, this, this and this. It's being able to think, that's working, we could put more money into that, or a little bit of a tweak here will make it work better, or there's this new need that's becoming apparent that we hadn't thought of before, so let's see what we can do about that. I talked about the rising risk earlier on. It's another one of those, I suppose it's a bit of a buzzword term, but it's a recognition that people have got chronic disease, but there's a whole bunch of people who do not yet have chronic disease, but are going to get chronic disease just because they are. And it's working on those people to, if you like, delay or hopefully prevent it, but more importantly, delay the onset or delay the need for having to have expensive health interventions because they've been managed early on. You don't wait till someone's got 3 chronic diseases and can't walk 10 feet. You actually get at them when they just got asthma and work on it so that the others don't all build on it before you do anything about it. Data-informed practice, again, I've mentioned data a couple of times. There's a really large amount of what you would term as good data available at the moment, which can very much say, this is what the need is, this is where the need is. And it's being open and transparent. So we don't get up and say, guess what, you need to provide services in Cardinia for this reason, or you need to provide services in Cardinia. We say, Cardinia is a place and here's all the data, have a look at it so you can see why we think Cardinia is the place. So it's, don't just accept what we say, have a look at the numbers that support what we're saying as well. And being transparent, if the activities don't work, I mean, we're required by the federal government to have all of our work plans on our website. So you can get onto our website and have a look and see what's our annual work plan for chronic disease, and that'll say this is what we're going to be doing. We finally got it approved yesterday or the day before by the federal government, so it should be on the website imminently, and that's what we're going to do. And so we will report against that. So if we don't do it, we've got to justify why we didn't do it. And probably most importantly, it's about being long-term sustainable. Those of you who have been in this sector for a while will know that there's lots and lots of pilots and projects and you get your $20,000 or your $30,000 and it lasts for 6 months or it lasts for 12 months, then you spend another 6 months writing a report and then nothing happens. Any of the momentum you might have got is gone because the project itself didn't particularly talk about how the change was going to be sustained, it just talked about the change. And so we're looking to make a lot of the stuff that we do sustainable. So if we give a general practice $100,000 to do care coordination better, then we expect them to be putting things in place such that when we cease giving them $100,000, they can still do it. And that happens by sort of substitution of services and teaching them that they can actually bill a Medicare item for this, this and this, which they might not have been doing. And if they do that, because they've got their good coordination processes in place, they end up getting enough money to pay for the coordinator that they've purchased out of the $100,000 that we've given them. So it's, you want to do this, let's make it sustainable. And we try to do that with everything that we do. Mostly it works, but it doesn't always work. And that's also part of it, but at least a majority does. Whereas when you're talking little projects and little pilots that never continue, even a brilliant one, if you don't continue it, then you might as well not have started it. Oh, hang on, sorry about that. So the commissioning process. So as I said before, it's a continuous process. So we look at the needs and priorities, we do the strategic planning, we do the contracting and procurement, we monitor and manage performance, we review services, we assess needs and priorities, and round it goes. So it's a continuous process to ensure that it's being refreshed regularly, and it helps with the sustainability of it. And it means you can be a bit agile about what you're doing because you recognise there's a new need or a new issue that you can be quick to do something for. Okay, so what might it mean for organisations such as yours? Oh, sorry. Okay, greater involvement with other health providers in the area. More formal coordination or collaboration in terms of designing bundled services, a better understanding of the business needs and models and how much it costs to do things, different approach to clinical guidelines and patient record keeping so that collaboration can occur and services can be better integrated, and then investment in training and systems, because nothing's going to change if you don't teach the staff how to do the things the better way and have them learn and understand that it is different and it is better. So it's about engagement, which has been variable previously, I think. So what do the PHNs do in relation to chronic? So what we've covered is, if you like, some of the broad stuff, but what do we actually do with chronic disease? So the individual PHNs determine what they're doing. So this is that, call it $5 million that we've each got for that, which in the overall scheme of things isn't very much. We have 330,000 people with chronic disease in southeast Melbourne, and we've got about $5 million to spend on them. You do the maths, and we could give them $50 a piece, and that's about where it's at. So we need to be quite targeted and quite clever, if you like, about how we distribute the funds. So each PHN does its own determining of what they're going to do. The aims and the outcomes have to be consistent with the broader PHN goals. So as I say, we're all doing largely the same stuff, but there is differences. And what I can talk about now is what we do in South East Melbourne PHN, which, like I say, will be similar to what the others do, but not identical to what the others do. See, you're learning tricks of how to drive this. Two clicks make it go, it seems. So the landscape for chronic disease is changing. 10 years ago, chronic disease, you had COPD, you might have had asthma, and that you might have had MS, you might have had one thing which was considered to be a chronic disease. These days, multimorbidity is Part of that is because people are getting older, so they're actually getting to the age where they get more stuff. Part of it is probably because we're not as healthy as we used to be, so there's things that are happening that didn't used to happen. But certainly that's the norm, and when we talk to our GPs, they're very much aware that, you know, they've got patients with 2, 3, 4, 5 chronic diseases where they never used to have patients with that many. Maybe we're diagnosing better, but it's certainly the management for people with multiple chronic diseases is necessarily different to people who have only got one. So it's a big part of what general practice does. In some of them, it's 70, 80% of some of our practices. It's about chronic disease, not just with old people, which you sort of intuitively think, but it's a big part of what they do. And the way general practice and the health system in general, I suppose, is structured, it doesn't always encourage the best practice response for chronic disease. And that's some of the stuff that we're trying to work with practices and organisations to change. And improving the quality of primary care. All general practice wants to do it. Many of them don't know how. But ultimately, it's the patient's family and community who get the key benefit from doing things differently. Now, those of you who've dealt with general practice over the years will know that as a generalised comment, they are resistant to change. Some of them are quite happy to change, but the majority are quite resistant. They've really got to see the benefits and be convinced that people other than them actually do know what could be best for the patients. And those of you from particular disease-specific organisations will be very well aware that you've done lots of work on how to manage this, and your GP hasn't done as much, so doesn't know as much, but still thinks he knows better than everybody else. That's not all GPs, but there are a good number that have that underlying attitude. Okay, so the sort of stuff that we do, I think I've got the right slide. So we support general practice to identify priority population groups who have poorly managed conditions. So a lot of there's a bit of a theme here you might have picked up. It's about the people whose conditions aren't managed well. Some people have excellently managed chronic disease conditions, others it's really poorly managed because they've got poor social indicators, because their GP is not very interested, because they're not very compliant with what they're doing. There's a whole variety of factors that contribute to the poorly managed. There's a high correlation between risk factors for chronic disease and prevalence, which means targeted preventative health is very important. This comes back to that rising risk group we were talking about before, helping people to understand. I mean, the last few days there's been a whole bunch of stuff about alcohol use and the alcohol intake of people in the sort of 50 plus age group, which is as bad, according to the latest data, as in the 18 to 25s. So there's obviously been some reports come out, but it's helping people of our age, or my age at least, understand that having 2 or 3 beers every night whilst you're fine is actually akin to a teenager going and gets slammed every Friday night. It's almost exactly the same in terms of the impact. And so this is education so that it prevents people from participating in what you might call risky behaviours, but behaviours and practices that are not beneficial for their long-term health. And quantifying the rates of comorbidity and multimorbidity within so this is about some of the stuff that we do in our area, is to what are the rates? Are there pockets? Are there practices? We have immunisation data which shows that one practice in one suburb has one GP who doesn't immunise, but we've got 2 practices in another suburb and none of them immunise. And so it's getting that level of data so that we can work with particular providers, and we have the same with chronic disease. There's practices where every patient have got a chronic disease management plan, and there's others where nobody has, right next door. It's the same community, it's the same patients. So we try to work with the ones who don't have these things to bring them up to the appropriate level. Okay, so everything that we do has to be based upon outcomes and the so-called outcomes frameworks. All PHNs have got outcomes frameworks, and we are measured by the federal government on our performance against our... So every activity we do, we have to be able to say, we're doing this and it's going to address outcome 1 or outcome 2 or outcome 4. And so its uptake of healthy behaviours is fairly straightforward, I suppose. Access to chronic disease services, high quality and appropriate chronic disease management services, and the sector capacity to manage chronic disease. So everything we do in the chronic disease space, we've got to say we are funding practices to improve their chronic disease management. That's going to address outcome 4, outcome 3, and maybe outcome 2. But if it's not going to address any of them, then it's not an activity that we can do, because we're going to get kicked around the room by the government for spending their money not on what they wanted it spent on. Okay, so what specifically are we doing? So we have 4 key chronic disease activities. Healthcare, and I've got a slide on each, so I'll go over them briefly now. Healthcare homes. Now, we're the only PHN in Victoria who is a healthcare homes trial site. There's 10 trial sites around the country, and we're the Victorian one. We have hospital auspiced community health services, so that's funding some of the community health services that are specifically auspiced by our 3 public hospitals. General practice capacity building, so that's improving the ability of general practices to actually do what they should be doing. And priority population groups, which is targeted at the practices who are already doing a good job, or who already think they're doing a good job. Done it again. Okay, so healthcare homes. Now, you've probably read or heard a fair bit about healthcare homes. There's various noises or otherwise in the media about it. It's about patient-centred care around the patient's needs. Now, we will have 23 practices in South East Melbourne, are healthcare homes practices. To put that into real context, we've got about 480 practices. So it's a small number of our practices are going to be healthcare homes in the first round. In theory, the trial goes for about 18 months, at which point the government is probably going to roll it everywhere, assuming that it works. The key aspect, well, there's probably 2 key aspects of it. It's patient-centred care, and it's a real focus on patient-centred care. And appropriate patient-centred care is one thing that any practice can do, and one of our other activities supports that. But the other important thing about the healthcare homes process is it has capitated funding. So what that means, in short, is that currently when a patient goes to see a GP, and a patient with sort of if you like, a decent level of chronic disease might see the GP 20 times a year. The GP needs to see the patient every time. Otherwise, the practice or the GP and the practice don't get any money for it, because the money, I mean, there's a few other bits and pieces, but generally the money's tagged to the general practitioner, which means that there's a bit of maybe a disincentive to do other things with the patients, because how are you going to afford it? You know, it's going to eat into the running cost of the practice, it's going to eat into profitabilities, all those sorts of things. So what the government are doing, they've worked out that based upon a scale for the patients, that depending how the patient ranks in one of 3 tiers, the practice, not the GP, but the practice will get a fixed amount of money. So your patient who sees the GP 20 times a year is probably one of your sicker patients. So the practice might get $1,800 a year, because they've worked out that that's about on average what the Medicare is for those patients. The practice can then do exactly what they like with that $1,800 a year. So they can have the patient see the GP 20 times. They can have the patient see the GP 10 times. They can have the practice nurse see the patient 5 times. They can have a diabetes education session once. They can have a COPD education session. They can pay for the patient to have a home medicine review. They can pay a small gym membership if they want to, which they might consider are good things for the patients. But previously, where were they going to get the money for the gym membership? Where for the practice nurse? Medications review does have some numbers, but you could do more with that. So it enables the practice to do different things which support the patient, which goes back to this understanding that the best person to manage a patient's condition isn't just or isn't only a GP. There's a whole range of other people who can provide equal or better quality of support, but currently don't because the money isn't structured such that they can do that. And when these patients get a cold or something like that and need to go to the GP will still be able to charge a normal item for that. So the capitated funding is only related to their chronic disease stuff. They'll also need to have all their chronic disease care managed from one practice. So they won't be able to go to this practice and this practice and this practice. All happens in the one place, and what that in theory means is the coordination is done better because one practice knows everything that's happening for the patient. Every time. We're also funding the hospital auspice community health services. So most of the public hospitals have got a community health service attached to them. And the support that we provide is largely to help manage patients post-discharge, so that there's a real disconnect between patient leaves a hospital and almost, as far as the hospitals are concerned, although their attitude is improving on this, the patient's gone from them. They sort of don't care. They often, as you would well know, don't even tell the GP the patient's gone. Certainly don't tell them that they've changed all the meds or they've got this or they've got that. 2 or 3 weeks later, patient turns up at the GP and the GP has a heart attack because everything's different. So this is about supporting hospitals to help those patients post-discharge. So it's different interventions, acute and chronic. You might have heard of the state government's Health Links program, which is targeted at the frequent flyers who don't have that good link between hospital and general practice often. It's similar to that sort of thing, but it's getting the links between hospitals and primary care providers stronger, because that's one of the weak points in the health system at the moment, is that GPs or primary care, often via GPs and hospitals, don't seem to communicate terribly well and not consistently across the board. Okay, we're also providing a lot of money to practices to improve their capacity. So this is about coordinated care. We're actually funding 34 practices to improve their patient-centred care practices. So we've identified with a whole range of our practices what good patient-centred care is and what good care coordination is. And so we're funding a number of practices. They've had like a self-assessment tool, which they could see that, yep, we're doing this or we're not doing this, we're not doing this. You know, if we were doing all of these things well, we'd be doing a good job at that. And so they've been able to assess. So we haven't said you're doing a poor job. We've said, here's the tool, tell us what you think. And as a result, 34 practices are being funded to help them provide a better level of care coordination for their chronic disease patients, because they're the primary ones that need the coordinated care. This isn't to say those practices don't do it at the moment or weren't doing it, but these are the ones who recognise that it's not being done optimally. And it raises their capacity to manage these patients. It should engage the patients more. And there's a variety of training and education. It's not just here's your money, do it better. It's here's how we can help you do it better. Do this education, come to that session, share with your colleagues. We have a number of practices who think they do brilliant coordinated care. Some of those do, some of those probably don't, but that doesn't matter. The ones that think they're doing it really well, we've basically set them a challenge, if you like, to look at patients with complex health needs. The ones, and others, I've got a chart on that in a minute. So it's a bit like you're doing this great job with care coordination, so now go and find a group of patients who are not getting good care coordination because they're in the sort of the at-risk vulnerable type areas, and we'll give you money to extend your great service to those patients. So again, the outcome of that, we've funded 8 practices, and the outcome is there'll be about 1,000 patients across our catchment who have got chronic disease, who are not currently properly managed, who should at the end of 12 months be properly managed, and there'll be some sustainable systems in place. Yep, I've got 3 left. Okay, so the groups that we looked at are based upon demographic factors, so that's people over 65, humanitarian arrivals, Aboriginal and Torres Strait Islander community, culturally and linguistically diverse communities, and individuals experiencing homelessness. These are groups of people that are really hard to get at. The over 65s less of an issue, but still an issue, but the other groups are really hard to get at. So it's somewhat of a challenge for the practices, and it's looking at ideally COPD, congestive heart failure, moderate to severe diabetes, angina and asthma. There, when you look at the data I was talking about before, they're the ones that come up as the big ones, if you like. Okay, so we give out all this money, but we then report and evaluate it. So we've got to monitor it, how it's going, why it's going, is it working, is it not working? Because if it's working, we can use it in the next part of the cycle. If it's not working, we do something different next time. And learning some lessons and sharing. The PHNs are beginning to talk to each other about what we do that's good and what we do that's less good. Hopefully that'll mean that some of the stuff that's, you know, if Eastern PHN do something that completely doesn't work, then, and we know about it, we won't then do it ourselves, because at the moment we would do it, they would do it, and everyone would waste money on it. Okay. You can also interact with, so I talked about the websites before, but the PHNs have practice networks. I think all of them probably have practice networks, where there's an opportunity for practice nurses, practice managers to get together and talk about common issues, common problems. There's various education sessions that go with that. It's not just open to practice people, it's open to anyone who's got an interest in that area. We have a lot of education and training events. Ours are advertised on our website and in our newsletter. The other PHNs would be doing exactly the same thing. You can subscribe to our newsletter. There'll be a link on the website that tells you how to do that, and that can tell you when there's education activities. We've just done one on thunderstorm asthma, so there's a variety of things that the education activities are done about. We have information sessions on pretty much all the stuff that we commission out, so anyone, again, is welcome to come along and learn about what we're doing, why we're doing, how we're doing it, see whether it's something that's useful or not. And we have a variety of consultation forums. So like I said before, we don't just say we're going to do this, we actually get a bit of consultation happening so that what we decide we want to do is based upon people's real needs. And that was the last slide. Thank you.